let's talk about, I guess, workforce training and well-being, which is again a very big area of concern, I think, for a lot of us. Like you mentioned, like how many, you know, doctors have left general practice and how it's not such an attractive discipline for a lot of young, medical students. When they come to our practice and they come for their placement, and you say, "Hey, are you gonna take this up as a career?" Well, I don't know. It seems very difficult. We watch how you guys have to do so much. You are responsible for sifting through such a heterogeneous representation, whether it's life threatening or not, which system, which body part, from cradle to grave. You guys have to, swing your mindset every 15 minutes. They find it very challenging, and they can see that the time pressures are enormous. So how are we going to make sure that we make it an attractive area of medicine, and how do we recruit and then retain those people?
Mm. Look, this is a fantastic question, because there are multiple layers to this that are really important for us to grasp, and then for us to prosecute when it comes to policy and funding. In Victoria, we were the first state, and I am very proud of my advocacy in this, to achieve the $40,000 stipend, the Victorian stipend, in recognition of the fact that registrars take a significant income hit when they enter general practice in the first year.
Yes.
And we achieved that stipend, and then that was taken up nationally, and it's now a permanent national policy of the federal government. So I think recognising that loss of income was a significant issue, and we have had a much bigger influx of registrars entering training as a result of that. But it's not only about that. I think that we need to talk about rehabilitating the reputation of our profession. And a absolute priority for me is to wrest back respect and recognition for our profession, not only from government, but also from the media and from
Yeah.
patients themselves, and from non-GP specialists.
Yeah.
Now, in fact, quite a lot of non-GP specialists tell me that they would stand beside the college and make it clear to government that the whole health system would collapse without us. And I
Yeah.
intend to recruit those people to help
Perfect.
prosecute the argument about our value. But we really need that pressure to be coming from the media and patients as well. And so I want registrars to have pride and excitement about entering what I still believe is the single greatest specialty in medicine. There's nothing better than being an expert generalist. I can treat any condition, any age, and I have a whole heap of skills across different body systems. It's a very good feeling to be that well trained and to have that much knowledge and skill. Now I need the rest of the world to understand that that's what I'm capable of. And in particular, when I think of our RGs with advanced skills, who are doing anaesthetics and obstetrics and palliative care and emergency medicine, and unbelievably talented and gutsy people. And I think that their value in our health system is, if any of us were marooned on an island or in an apocalypse, the one clinician I would want to be marooned with or in an apocalypse with is an Australian GP, rural generalist with an advanced skill. They are so well trained. So I want that pride to return. I also want people to be proud to be members of the college. And so I think that there's a lot we can do to help people want to enter training. I think that there's some bureaucracies inside of the college that we can dispense with.
Yes.
I think we need to ask ourselves, we need to ask the government, what is all the dumb stuff that you're willing to get rid of?
Yes.
Unless it improves quality, safety, and transparency, dispense with it, because you're making everything too complicated. And every time government applies a new layer of regulation, it costs everyone more money. So you need to be very sure that you're going to produce value with that extra regulation, because often all that happens is the cost of everything just skyrockets.
Yes. And to your point about like being recognized for the special skills that these GPs have when they're working in these rural areas or regional areas, and they're not recognized. I mean, a good example, even in metropolitan areas, is marina insertions. Like, what is the rebate? Paltry. It's disgusting compared to what a specialist earns. A gynecologist once said to me, "Why would you, as a GP, want to take the medical legal risk of inserting a marina for getting paid peanuts?"
Hmm.
So that's the thing. Now, there is a question from the audience. The AMA they do have their recommended fee schedule, which is significantly above the government,
Mm.
schedule fee. Does the Arista GP have an intention of trying to give us a similar, maybe, model?
Absolutely. I think that we need to say this is what our services are worth,
Yeah.
and the rebates fall woefully below that. They're less than 40% of what our services are worth. And now I've said, and I would continue to say, that I think GPs should charge what they are worth.
Yeah.
I do understand that many GPs just feel that they simply cannot charge some
Mm.
of their populations. But I also would put the challenge out to all of us that I don't believe that any GP in Australia should be paying out of their own pocket, out of their own revenue, in order to conduct a procedure on one of
Yeah.
their patients.
Yes.
So I draw the line at saying, if you're willing to bulk bill because you can make incentives work, and you can use item numbers to your advantage, that's great. But the most expensive part of our business is the treatment room. And I
Yes.
hear year in, year out, and when I tour around Victoria, that people are losing money on doing
Yeah.
procedures. And I think that that is absolutely unacceptable. I know that if we said to a patient, you need to travel somewhere else to get your skin cancer removed, it will cost that patient significant amount of money in petrol and in lost earnings and in taking days off, etc. So I
And
really struggle knowing that GPs are paying out of their own pocket in order to deliver procedures.
And the stupid rules, like you can't charge for dressings, very expensive dressings that we need to use on patients day in and out for chronic wounds, because it's called, you're doing illegal sort of billing there because you've billed an item. You can't charge separately if you are delivering some extra, care to the patient. So a lot of practices then say, well, we'll have to then send the patient away to the pharmacy to buy those dressings. A lot of inconvenience, very expensive for patients to buy single dressings, but we just then suck it up and we just give them dressings without charging for it. So there's lots of these areas of leakages and real losses in the treatment room that you just alluded to. Talking about career proposition, you know, uh, look, female GP force in Australia have become a central pillar, right, of healthcare. And women, even though we make up half of the GP training pipeline, they kind of really are penalized, I feel, in terms of the Medicare rules. So it's almost like a gender penalization pay gap, because women GPs tend to spend longer during consults, see the more complex patients, do a lot of women's health, do also a lot of chronic disease. Mental health is they attract a lot of mental health, right? But they don't get remunerated, commensurate with the time and effort they spend. And a lot of them work part time. So for them, working part time, seeing fewer patients just doesn't make it financially viable to have nannies or daycare for their children who they leave to come to work.
Mm.
And we are disincentivizing these, critical, workforce of general practice.
Yeah. Look, Mark Butler made the comment that he's not aware that there's any gender pay gap or disadvantage for female GPs, or any data that demonstrates that. And I think that there was not a single GP and patient really in the land who believed that that was a genuine comment. All you need to do is go on the ATO website and you can see the data. It's
Yes.
presented in graphical representation. So we all know that this is a reality. And if we've got a government that says that actually cares about women's issues and it cares about women's health, then it needs to recognise that it must support female GPs to deliver the care that they do, which is complex care.
Yeah.
Now, the government signalled to me that it's contempt for the work that female GPs do by removing their mental health item numbers, and I think that they did that because they felt that we should not be co-billing, and so it is an absolutely essential that we take on that fight, because we are going to lose our female GPs, and so that is a hill I'm willing to die on. Is that we need fair remuneration for people who are doing the heavy lifting. The fact that the MBS returns you less and less remuneration per minute that you spend, would
Diminishing
create
return. Yeah.
perverse incentives that we have been warning about and talking about for 2 decades. And in actual fact, rather than heeding our warning, they doubled down on it with the bulk billing incentives from last year's announcement. Now, we're all bearing the cost of that because we now actually have general practices in the country that have got signs up saying you will only be able to discuss one issue each consultation. We're not doing more than one issue. Now, that is so illogical. And all it means is that people still have the same care needs, but they have to come to the general practice on 3 different days to deal with 3 different issues. I think that it is so illogical, but it also means that we're delivering lower value care, and patients are taking time off to attend 3 separate appointments, etc. So we need to defend the value that people who are willing to take time and do complex medical care and make it clear that by doing that care, you keep people out of hospitals. So I feel very strongly about this one, Anita. And just going back to billing, I am very committed to advocating for decoupling gap payments from bulk billing.
Yes,
that a
that would
patient
be a really important, move for all GPs.
Yeah, it's just another coercive control strategy that basically forces practices to bulk bill, and I think it needs to be dispensed with as a matter of urgency.
Let's talk about GP registrar training policies and what the framework is. And are you seeing any possibility of changes that will positively impact on that sort of part of RSCGP's role, because they've taken over now the role of GP training? How can we make sure that practices and supervisors are well remunerated for the effort and time? Like, I know I've got registrars, and boy, how much time and effort is spent, you know, supervising them, teaching them, and helping them out. Besides the protected teaching time, there's always on the go, continuous, help that you have to give them. Every time I'm away from the practice, I feel so guilty. I give them my phone mobile to say, call me anytime, and we're talking on the phone constantly because I just feel they are my responsibility. But that's all unpaid work for me. Or instead of seeing patients, I'm spending time with them. And
Yeah.
I don't think the payments reflect that.
No, of course they don't. And look, this is just a metaphor for the entire relationship that we have with our funding systems in general practice. There is an expectation that we will fill the gap with our love of the profession and our commitment to our patients in the future. So appropriate remuneration for supervisors, absolutely. We've been asking for it now for some years. And look, I do accept, and I invite people to understand that you never go to Canberra, ask for something once and get delivered it in a single advocacy cycle. You do need to be at it year in, year out, and eventually a budget cycle will come across where there's an appetite for pulling the trigger on an idea, and then it happens. So I think one of the things I've got is the experience to know that advocacy is a long game, and that you can advocate for some years, and then the themes are in your favour, and then you can get the funding asked across the line. So I'm not prepared to give up on the issue of supervisor funding. I also recognise that we actually need to make it much easier for registrars themselves to access their flexible funds, and for there to be more transparency and ease of dealing with the red tape of training, and making sure that they're accessing all of the grants and the things that are available to them to make their training easier. But I'm not going to give up on supervisor payments, because I think what we need to recognise is a person who's willing to share their expertise and teach is a unicorn, and they should be treated with great respect, because without them, there is no future of medicine at all.
Yeah. So talking about being, respected, validated, and recognized, let's talk about IMGs. We know that IMGs form a major segment of, the health force, especially in rural and regional Australia and workforce, and they are really keeping that system alive. Otherwise, we would not have any healthcare in many areas of Australia. I'm going to now talk as an IMG myself. When I first arrived in Australia, without too much self-revelation, I could say that I quickly realized that the path to being registered as a GP in this country was not just academically rigorous, which it should be, but structurally very exclusionary, I'm sad to say. I come from a nation of people whose command of English is a well-recognized, thing globally. I mean, we have Nobel laureates in English literature. In my AMC exam, I was actually asked, "How come you speak such good English? Did you learn to speak it when after you arrived in Australia?" Which then reflected a pretty distinct,
Mm.
bias to me straight away. And that kind of really made me much more, I guess, compelled to recognize that we need to do something. And RSAGP needs to do something to ensure that the brilliant global talent that enters our country is not met with structural, sort of like obstacles and
Mm.
unnecessary barriers.
Mm. I feel very strongly about this one, Anita. And the minute I became chair of Victoria, I started receiving requests for assistance from IMGs to
Mhm.
resolve bottlenecks or being caught essentially in a loop
Yeah.
where the requirements of the various systems clash in such a way that people just end up going around in a circle and they meet the requirements of one regulatory body only to slip through the cracks of another one and then having to either start again or being told that they
Yeah.
need to exit
Yeah.
or that their visas are
First,
in jeopardy or they need to go back to the beginning of training, or in some instances, go back to hospital and then
Mhm.
gather more experience and then come back. So this bothers me deeply. The CRUC review certainly put a lot of this under the spotlight. And I remember giving my expert advice at the CRUC review. And I think that we've still got a long way to go there. It pains me to tell you, but the reality is we still do have a lot of racism in
Oh,
healthcare
okay.
in our country.
Yeah.
That is
No.
racism towards patients, racism towards doctors,
Yes. Yes.
and that is an absolute priority.
Yeah.
But we need to be, there's two elements of what we can do here, Anita. The first thing is that we have to advocate to the external agents to say we have to be more streamlined and there needs to be a greater sense of logic. And the deadline of being on your path to fellowship within 4 years of commencing just does not recognise the fact that there are significant bottlenecks that each of the regulatory bodies adds to the burden of the journey and the trajectory of the IMG. So we need to have greater flexibility and recognise that 4 years actually can be a very unrealistic deadline to meet.
Yeah.
And then we also need to look inside the college and say, well, where are our own processes adding to that with red tape, or where are we clashing with what we know is happening with the other external peaks? And I've long wondered, and I would like to ask the question about the AMC exam, because
Yeah.
I do wonder if there is an exam where the pass rate is in the 20 to 30% range, is the
Yes.
exam the right exam? And we've been told for decades that the AMC exam represents the standard of Australian medical graduates leaving university. And I've always thought it would be very
No, it
interesting.
doesn't. Having done it myself, I can tell you, I have done MRCP exams. I've done so many international exams, American exams. This exam was a league of its own.
Correct.
I thought it was an exam meant to fail you, not to actually test your. So, no, absolutely not. And I think there was someone I read somewhere soon after I finished the exam that they tested Australian graduates on that exam and they performed miserably.
Yeah, that's right. And I say, well, let's just go head to head.
Yeah.
Let's have a cohort of IMGs and a cohort of just graduated Australian medical students and actually test that theory, because I am deeply concerned that we are setting people up to fail. And of course, once you enter the country, if you think about what somebody does, they've left their country, enormous expense.
Displacement for their
They've come
family.
in, they can't earn because they can't practice their craft, and the fees to enter, and then the fees to register, and the fees to sit exams. Now, I defend Australia's right and responsibility to uphold a very high medical standard.
Yes, we do need to maintain that standard.
But I've been a medical educator for 15 years and I've been involved in writing exams and standard setting exams. And my question is the exam the right exam if the pass rate is 20 odd %? And so I'm very interested to ask those questions.
Yeah, no, be fair.